You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is July 6, 2012, and I'm your host, Dr. Jay Portnoy. Our topic, primary immunodeficiency. Our presenter is Dr. Francisco Bonilla. He's an assistant in medicine and the program director of clinical immunology at Boston Children's Hospital. Dr. Francisco Bonilla is at the Harvard Medical School at Boston Children's Hospital in Boston, Massachusetts. And Dr. Bonilla was also the editor of the recent practice parameter on immunodeficiency. I understand that that's being updated now. There's always new information about primary immunodeficiency. So infections, of course, are a common problem with our patients. They come in and they have allergic symptoms. A lot of times they have recurrent respiratory infections and so on. And as allergists, our job is to figure out who has a problem and who is just getting the normal range of common respiratory infections. And so we've asked Dr. Bonilla to talk with us about evaluation of patients with recurrent infections and to talk about primary immunodeficiency. Welcome to Conferences Online Allergy, Dr. Bonilla. I've got your slides right here, and if you'd like, I can give you control of the slides so that you can move them.
Thank you. So this isn't going to be so much about laboratory tests as the sort of clinical presentation. If I look on your schedule, it looks like you're having a talk on Monday about laboratory tests for immune deficiency. So let's start just by thinking about incidence and prevalence. I think a lot of people have a misconception that immune deficiency is quite rare. We don't really have a very firm idea of incidence and prevalence of all immune deficiency. Registry studies from 45 different publications to date put an incidence estimate at between 1 in 10,000 to 1 in 2,000 individuals, which is a cumulative incidence for all disorders of immune deficiency that's quite comparable to many of the more common monogenic disorders that we think about, such as cystic fibrosis, for example. It may even be more common than that. There was one recent random telephone survey study that was conducted in 2007, sampling about 10,000 American households in a random fashion, and 23 individuals in 18 households were identified in that study with various forms of immune deficiency, such as common variable immunodeficiency, IgA deficiency, IgG subclass deficiency, agammaglobulinemia, severe combined immune deficiency, and chronic granulomatous disease, and a calculated prevalence of approximately 1 in 2,000 children or 1 in 1,200 individuals of all ages, or an average of about 1 in 600 households with a 95% confidence interval for all individuals between approximately 1 in 800 to 1 in 2,000. So even somewhat higher than had been estimated by registry studies previously. So the take-home point is that when considering all forms of immune deficiency altogether, there really is a significant prevalence, and it's important to maintain an index of suspicion because many of these patients go undiagnosed for significant periods of time. In most classification schemes of immune deficiencies, we recognize sort of two main dichotomies between innate and adaptive immunity and cellular and humoral effector mechanisms. And we broadly categorize cellular effector mechanisms of innate immunity as phagocytic cells, monocytes, macrophages, neutrophils, and among the lymphoid cells, the natural killer cells. The major humoral effectors of innate immunity include complement and related proteins, and of course with adaptive immunity mediated predominantly by lymphocytes, with T cells being responsible for cellular mechanisms and humoral mechanisms affected by antibodies. And it's important to remember that classification is, these dichotomies are useful for classification purposes, but when you're talking about host defense, almost all of these mechanisms are operating simultaneously in concert, regardless of the specific nature of the invading pathogen. So the most recent classification, which is generally considered the most comprehensive and is being more or less used universally worldwide, is promulgated by the World Health Organization, International Union of Immunological Societies, and it's updated every 2 years. And this is the most recent one, which recognizes a total of 181 defined immune deficiency disorders based on both clinical and molecular genetic criteria. And we're going to sort of go through these in an overview kind of way in subsequent slides. Just to give you some idea of the different prevalence or what the fraction of all immune deficiency that's taken up by each of these different categories. This pie chart was made several years ago, and it looks at all of the published registries. As I said, there were about 45 studies, and classifies the patients reported according to the WHO IUIS classification. And you can see that at least for the populations reported in those registries, the majority of patients had some form of antibody deficiency, accounting for half of all immune deficiency that was diagnosed. The next largest chunk was this sort of other category, which carries a wide variety of different syndromes associated with immune deficiency, such as Wiskott-Aldrich syndrome, DeGeorge syndrome, ataxia-telangiectasia, and other rarer syndromes. Phagocytic cell defects, about 11%. The vast majority of these would be chronic granulomatous disease and a minor component of other disorders. The so-called combined deficiencies affecting both T-cell and B-cell function, about 8%. Included in this category, of course, is severe combined immune deficiency, as well as some less severe forms. And then the rest of the 10% or so of this pie is all the other categories together, which individually are relatively rare. And so these include complement defects, defects of innate immunity, regulatory defects, and autoinflammatory disorders. So I'm not going to go through all of these diseases in any kind of detail. They're listed here in the slides for your reference if you wish to have them. This is relatively up to date as of approximately December of last year. And as you may suspect, there are new gene defects to be added pretty much on a monthly basis. So among severe combined immunodeficiency, we distinguish them often on the lymphocyte phenotype. All SCID has negative T cells or absent T cells, and some forms of SCID B cells develop, and other forms of SCID they don't, and the gene defects associated with each category are listed below. And then these are other disorders that are included in the combined immunodeficiency category. Among the well-defined syndromes with immune deficiency, that's in the other section of that pie chart, as I mentioned. Very common disorders in that group include Wiskott-Aldrich syndrome, DeGeorge syndrome, a variety of DNA repair defects, some of the hyper-IgE syndromes, and other syndromes associated with immune deficiency. Among the predominantly antibody deficiencies, we have an array of mutations associated with agammaglobulinemia, other single gene defects that are associated with a common variable immune deficiency like phenotype, hyper-IgM syndromes, other forms of antibody deficiency. And then there's a variety of antibody deficiency disorders for which we really don't know the molecular basis in the majority of patients. And these include some of the most common disorders that we diagnose in the antibody deficiency category, such as common variable immunodeficiency, Good syndrome, which is sort of CVID with thymoma, and then selective IgA deficiency, IgG subclass deficiency, specific antibody deficiency, and transient hypogammaglobulinemia. And then there are a variety of immune dysregulation disorders, autoimmune lymphoproliferative syndrome, among the more common of these as a group relatively rare disorders. and then various forms of diseases that we group under hemophagocytic lymphohistiocytosis and other lymphoproliferative disorders such as X-linked lymphoproliferative disease, etc. And then there's the whole category of phagocyte defects, a large number of gene disorders associated with severe neutropenia that have all been described relatively recently, leukocyte adhesion defects, and of course chronic granulomatous disease, which is by far the majority of diagnosed phagocytic cell defects. There's a group of diseases known as Mendelian susceptibility to mycobacterial disease, and this group of disorders leads to mainly recurrent problems with mycobacterial infection. A variety of defects grouped under the heading innate immunity. However, the clinical presentation can be quite varied. Some of these, such as immunodeficiency, can be associated with susceptibility to a wide range of organisms, whereas other types of defects can be associated with very restricted clinical presentations, such as HSV encephalitis. And then the autoinflammatory disorders, often referred to as periodic fever syndromes, which can be grouped according to the molecular defects that are associated with them. And then finally, the last category are the complement defects, which are generally associated with either recurrent infections or autoimmune manifestations, or both. And so I'm going to go through all of those again in a somewhat more overview way regarding the clinical presentations. I just wanted you to have that list more as a reference than anything else. So when we think about the clinical presentation of immune deficiency, everyone generally thinks of recurrent infections, which is appropriate since the vast majority of forms of immune deficiency will present with some form of infection susceptibility. And I would say probably 80% of more will come to clinical attention primarily because of infection. However, we know that for many disorders, regardless of which category they fall in, that autoimmune disease and different manifestations of immune dysregulation are often part of the clinical presentation, and those represent often very important diagnostic clues that lead us down a particular path when we're thinking about which mechanisms of the immune system we want to investigate in different patients. So infections are characteristically more frequent, they are more severe, they generally are caused by common organisms. However, we also see unusual organisms in patients with immune deficiency, and they tend to be more resistant to therapy. Autoimmune disease occurs because immune dysfunction is not only associated with an ineffective host response, but the self-non-self discrimination is also not functioning properly. Hence, what immune function remains is often misdirected against the self. And then immune dysregulation, broadly speaking, refers to improper regulation of immune cell proliferation during immune responses. Immune responses don't get shut down appropriately and lead to unchecked proliferation that can ultimately lead to not only hematopoietic malignancy, but there can also be impaired tumor surveillance leading to cancers in other organs as well. So often the pattern of infections can be the first clue towards which mechanisms of immune function need to be investigated. As I mentioned already, antibody deficiency is by far the most common type of immune deficiency that we diagnose. These patients are characteristically affected by encapsulated bacteria, mostly sinopulmonary infections, mostly common organisms such as pneumococcus or Haemophilus, Moraxella, etc., as well as other common bacteria. Mycoplasma and ureaplasma are important infections in more severe antibody deficiencies. All of the common viruses tend to cause more severe disease. Occasionally, vaccine strains of enteroviruses can be a problem with severe agammaglobulinemias and rotavirus. And of course, protozoa can be a problem for these patients as well, particularly giardia. And so one presentation of antibody deficiency could be severe recurrent giardia resistant to treatment, for example. When we think about combined defects that affect both T cell and B cell function, the list of pathogens on the previous slide, of course, is included, but we begin to see other forms of bacterial infections, such as with listeria or enteric flora. Again, common viruses will cause more severe disease in these patients. We begin to see more susceptibility to fungal infections, such as Candida, Cryptococcus, Histoplasma, etc., pneumocystis, and of course other protozoa such as Toxoplasma. Phagocytic cell defects are characterized most often by recurrent infections with staph or enteric flora, and often Pseudomonas or Salmonella or Nocardia. The mycobacteria, often seen with chronic granulomatous disease, including vaccine strains, as well as with the group of disorders that I mentioned under the Mendelian susceptibility to mycobacterial disease. And then fungal infections are also very common in neutropenia or neutrophil function defects. For complement deficiency, the infection predisposition is very similar to antibody deficiency, since eradication of encapsulated bacteria is dependent on antibody working in concert with complement to opsonize them for destruction by phagocytic cells. So complement deficient patients often also present with recurrent cytopulmonary infections. We often remember that terminal pathway complement defects are associated with recurrent Neisseria infections, usually Neisseria meningitidis. And then autoimmune diseases are very frequent with early classical and alternative pathway components. Predisposition to lupus and lupus-like disease is the most common manifestation, and the reasons for that are not entirely clear. The group of innate defects includes some specific cytokine pathway defects. I think that I may have made this slide based on an older classification, because I think that this group got put into another category more recently, but you can go back and check. In any case, this is the group of Mendelian susceptibility to mycobacterial diseases, basically affecting the interferon gamma IL-12 axis. Salmonella is another pathogen in that group as well. There are defects of toll-like receptor signaling and NF-kappa B signaling that can also lead to more severe manifestations with many different types of organisms causing infections. And then we talked about the syndromes that are associated with immune deficiency. And in this case, not only will there be an infection predisposition with certain pathogens, but very often there are other features of the syndrome that lead you much more directly toward the diagnosis. So, for example, if you see a child, especially a boy, of course, because Wiskott-Aldrich syndrome is X-linked, who has eczema and thrombocytopenia with small platelets and recurrent cytopulmonary infections, then one would investigate directly for Wiskott-Aldrich syndrome, since all of the characteristic features are present. Similarly, if you see a child who has a cardiac defect in thymic hypoplasia and hypoparathyroidism, this is a characteristic presentation of DeGeorge syndrome. And there are many, many other examples of specific syndromes with a variety of clinical manifestations that will lead one more or less directly to suspect a specific genetic diagnosis in such a manner. So the diseases of immune dysregulation present often not with infection, but this is a category that will present often with a combination of autoimmune manifestations and allergies to both environmental allergens and often to food allergens as well. And very often there may be other associated features such as abnormalities of skin and hair pigment, hemophagocytic syndromes, lymphoproliferation and malignancy, and depending on the particular constellation of features, there would be a variety of defects that one would investigate in that type of a presentation. And then finally, among the autoinflammatory disorders, fever is one very common, probably the single most common feature among that diagnostic group. The pattern of fever can vary tremendously between the different disorders, and it can be chronic or intermittent and relapsing with various periodicity that can sometimes be diagnostically helpful. Those patients also often manifest a variety of forms of dermatitis or enteropathy similar to inflammatory bowel disease, and many of them are associated with growth failure due to the chronic inflammation. So the 10 warning signs of immune deficiency were developed probably more than 20 years ago now. These are more related to infection predisposition as opposed to some of the other manifestations that we've been talking about, mainly because our understanding of immune deficiency has evolved and expanded to some extent. It's been shown through both retrospective and prospective studies that these warning signs do not really serve as either sensitive or specific criteria for ultimately making a diagnosis of immune deficiency, but they do serve as useful teaching points when trying to raise both public and physician awareness of immune deficiency. I think one of the reasons that immune deficient patients often go undiagnosed for many years is because physicians have the misconception that immune deficiency is rare, number one, and for that reason don't often maintain an index of suspicion and tend to think that children in particular with recurrent illness are just unlucky in some way. So as I said, these criteria or warning signs are based mostly on infection predisposition related to things like ear infections, sinus infections, pneumonias, resistance to treatment with antibiotics, prolonged oral courses of antibiotics, need for IV antibiotics, growth failure, abscesses, thrush, several deep-seated infections, and of course, extremely important, the family history of immune deficiency. There are many, many circumstances where important family history is missed that can provide a very important clue that can be even required for care of patients that may may be admitted in an emergency room. I can remember a case of an infant who was seen with severe pneumonia. He was a few months old, and treated and discharged, who ultimately died, and it wasn't appreciated at the time that there had been a prior death in infancy from infection in the same family, and so sometimes those things can impact how you manage patients even in the short term. So a retrospective literature review conducted in 2007 looked at the types of infections that are seen as parts of the clinical presentation of patients ultimately diagnosed with immune deficiency. And I don't remember exactly, I think this spanned about 120 or so case series in the literature over the last 30 years roughly. And you can see that a very large fraction of patients presented with lower respiratory tract infection and upper respiratory tract bacterial infection as well, if we include the sinuses in that. And the reason for this is that, as I mentioned, the vast majority of individuals with diagnosable immune deficiency have an antibody defect, and these are the types of infections that we characteristically associate with antibody deficiency. And a not very close second organ system was the GI tract, with about 16%, and then skin, CNS, joints, and ocular infections sort of coming in afterwards. So by far, respiratory tract infection is the lion's share of the infection-related presentation of immune deficiency. The same study showed that there was an average of 1 to 10 years in delay of the diagnosis of immune deficiency after the initial clinical presentation. And I think that this suggests, although doesn't prove it, but it at least suggests that screening for immune deficiency in patients who are presenting with a lot of infections is likely to be cost effective, since prevalence is generally higher than we suspect. These patients undergo significant morbidity and mortality related to infections. The tests that we normally use to screen them by measuring immunoglobulins and vaccine responses are not particularly expensive, especially in the context of the cost of the disease to their quality of life. These arguments, I think, applies most to antibody deficiency because it's the most prevalent form of immune deficiency, but I think it can be extended to other relatively common forms of immune deficiency as well. So if we're maintaining an index of suspicion about immune deficiency, of course, the history of infection is going to be prominent, but we don't want to forget the associated components of autoimmunity and other deregulated immune responses, because those are going to give us important clues about where we need to hunt within the immune system for the particular defect. It's always important to remember that there can be conditions other than immune deficiency that need to be investigated in patients who are presenting with recurrent infections, particularly with recurrent respiratory tract infections, whether it's otitis media, sinusitis, bronchitis, pneumonia, etc. As you're all well aware, there can be non-immune deficiency components such as allergy alone or sometimes in concert with some forms of immune deficiency, anatomic defects, other gene defects, ciliary dyskinesia, other anatomic problems. In adults in particular, it's also important to consider possible secondary immunodeficiency. Remember that common variable immunodeficiency, which is the most prevalent antibody deficiency in adults, often has its onset in adulthood. And sometimes it can be very hard to distinguish CVID from an antibody deficiency that may be resulting from immune suppression that had been administered for treatment of a malignancy or immune suppression related to solid organ transplantation and so on. But sometimes patients will have persistent hypogammaglobulinemia following a brief course of chemotherapy or radiation therapy, but the hypogammaglobulinemia may persist. And we think that in some individuals, these kinds of transient immune suppression therapies can lead to prolonged immune suppression, in a sense unmasking a genetic predisposition to an antibody defect that was pre-existing. That's all fairly theoretical at the moment and won't really be well understood until we understand the genetic basis of these disorders better. But it is something to keep in mind.
Is that also commonly found with treatments for like rheumatic diseases, like rheumatoid arthritis?
So we don't see that much in the way of antibody deficiency complicating patients undergoing the standard therapies for things like rheumatoid arthritis or lupus. And I think it's a matter of degree. The degree of immune suppression that you would administer to someone with RA or lupus is sort of an order of magnitude less of what they would probably get for something to prevent solid organ rejection after transplant or of the nature of a chemotherapy for a malignancy. And those types of treatments would be more likely to lead to a persistent immune problem in someone who is genetically, we believe, in someone who is genetically predisposed. So moving on to physical examination, often there can be important clues. I mentioned that there are specific syndromes such as Wiskott-Aldrich syndrome, where you'd be looking for eczema, DeGeorge syndrome, where there are characteristic facies, hyper-IgE syndrome is associated with a certain characteristic facies, etc. There are syndromes of skeletal dysplasia associated with immune deficiency, etc., etc. So that's important to keep in mind. Failure to thrive is often the component, so you want to follow the growth curves in children. There are various forms of dermatitis and ectodermal dysplasia that can be seen. The presence or absence of adenopathy in some cases is informative. For example, boys with X-linked agammaglobulinemia usually have no tonsils whatsoever. And if you see a young boy with lots of respiratory infections who has no tonsils, that by itself is quite unusual. And then, of course, we often will see the presence of an acute infection or the sequelae of past infection on exam as well. And then, finally, laboratory testing, which I'm going to talk about in a relatively general way. We usually use a stepwise approach, as in many forms of disease. There are certain tests that you apply as screening tests in order to see if you can pinpoint where a problem might exist, and then move on to more advanced testing to try to reach a more specific diagnosis. So with regard to humoral immune function, obviously we measure serum immunoglobulin levels. A common mistake, I think, is to stop there. And sometimes people will check an IgG, an IgA, an IgM, and if it looks normal, then they say, oh, okay, you don't have any humoral immune defect. But you can't stop just by looking at serum immunoglobulin levels. You really have to look at antibody function. You need to determine that the individual is or is not capable of making specific antibody to vaccine or infection challenge. And if your initial testing suggests that there may be some low level or low response to past immunization, it's often useful to administer booster immunization and assess the response after. If you determine that there is some either low immunoglobulin or impaired antibody response to vaccine, then you would want to move on to look at the number of B cells in circulation, and nowadays even to look at different B cell subsets that can be informative regarding particular molecular defects, and then move on possibly to functional testing, and then of course molecular methods that might establish a genetic diagnosis. We look at IgG, IgA, IgM, and often IgE. There's very little clinical relevance of IgD measurement. IgG subclasses are a little bit controversial. Some people believe they should be measured. Others may argue not. At least in many circumstances, I will often look at subclasses, particularly in children. But it's important to remember to use age-adjusted reference ranges. Obviously, in children, that's the most important. I've had many kids referred for quote-unquote abnormal immunoglobulins because they were compared to an adult reference range. So whenever you're looking at immunoglobulins, lymphocyte populations, etc., you have to use age-adjusted ranges. The antibodies that we look...
We've had the same experience. Yeah.
Yeah. The antibodies that we look at are common vaccine antibodies, tetanus and diphtheria toxoids, the polyribose phosphate associated with Haemophilus influenzae, pneumococcal antibodies, and so on. And again, if antibodies seem low on the initial evaluation, we'll often administer a booster to look at the response. At least on initial evaluation for flow cytometry, we'll enumerate the major lymphocyte subsets, CD4, CD8 T cells, B cells as determined by either CD19 or CD20, and then a combination of markers to look at natural killer cells, which are defined as lymphocytes that do not express CD3, but do express either CD16 or CD56. And it's also important to keep in mind that both the percentages and the absolute counts are important. You should, and if you're going to pick one to look at, then pick the absolute count, because that really is the most important determinant of whether the lymphocyte population is normal or abnormal. But sometimes we look at both. But really the absolute count is the most important, and should be determined in every circumstance. And again, you really want to look at age-adjusted reference ranges. So, of course, screening tests are flow cytometry to look at the lymphocyte populations, but just as it applies to antibody function, you also want to look at cellular immune function. The easiest and the cheapest way to do this is with the cutaneous delayed type hypersensitivity, or DTH test. Nowadays, some of the common antigens that we used to use for that, you can't find anymore. There's a Bonilla antigen that is available that we use routinely. Some people I know will use an intradermal injection of a tetanus vaccine in the same way, although it's not quite the same as using the purified tetanus toxoid for the testing, because it contains some other components that might cause an irritant reaction. So, but still some people will use it. But the Bonilla antigen is available. The cutaneous DTH is useful in kids generally above the age of 1 or 2. Doesn't work so well for younger kids. And it unfortunately is prone to interference from a variety of things. Medications, intercurrent viral illnesses, and so on can often suppress the skin DTH response. So if you don't see a good DTH, you might want to confirm that by looking at an in vitro test, which we do all the time, of course, although it is much more expensive than the skin DTH and maybe a little bit less desirable for that reason. But in any case, when we're looking at in vitro tests of function, responses to T-cell mitogens and antigens are probably the most common tests that we order. And then we will, of course, look at other functional tests like natural killer cell cytotoxicity or even activated CD8 T-cell cytotoxicity, cytokine production assays, enzyme measurement, and molecular methods as well. So this is, I think, a very important slide, and this is just looking at the lymphocyte number by age. Most people who take care mostly of adults, they think that the lower limit of normal of your lymphocyte count is, somewhere around this level between 1,500 and 2,000. This is 4 years of age. This is birth. This is the 5th percentile. This is the median, and this is the 95th percentile. So you can see between the ages of about 1 to 6 months, the 5th percentile lymphocyte count is right under 4,000 cells per cubic millimeter. And what often happens is that someone will look at a level of 2,000 in a 6-month-old and say, oh, that's 2,000. That's no problem. When in fact, this is way below the 5th percentile for a 6-month-old. The normal lymphocyte count in the 6-month-old should be greater than 4,000. So I've seen many cases of severe combined immune deficiency that were not appreciated early on because they had lymphocyte counts of a few thousand, and people failed to appreciate that that represented really significant lymphopenia in that population. So this is something that is important to keep in mind. In the days ahead, as newborn screening for immune deficiency or severe combined immune deficiency is progressing nationwide, maybe this will take a little bit of the pressure off. However, I still think it's important to keep this in mind because there may be forms of immune deficiency associated with lymphopenia that might not be picked up by newborn screening, which will require you to remember this important fact. Moving on to phagocytic cells, the CBC represents the first screening test since severe neutropenia can be an important phagocytic defect, although they're not very common. And even just looking at staining of neutrophils in peripheral blood can sometimes be very informative because some disorders of neutrophil function are associated with abnormality of the neutrophil granules that you can see just by doing H&E staining. And then, of course, there are a variety of more advanced tests that we can do different assays of oxidative function to look for chronic granulomatous disease, flow cytometry to look for adhesion defects, and then other functional tests for neutrophils that can be sometimes helpful in diagnosis. And then finally, the complement system. There are 3 pathways of complement activation: the classical pathway, the alternative pathway, and the lectin pathway. The defects, complement defects as a whole are relatively rare, and almost all that are diagnosed are defects of the classical pathway. Alternative pathway defects are very, very rare. We have not diagnosed a single one in our program in the last 20 years, and so they are pretty uncommon. The lectin pathway is controversial. As many as 3% of children will have quote-unquote abnormally low or deficient levels of mannose-binding lectin. So the degree to which low levels of mannose-binding lectin predispose to infection in children is still very controversial. But there are clinical tests that can measure lectin pathway function. So if a screening test of complement function is abnormal, then we would go on to look at the levels or function of individual components to see if we could identify where the abnormality exists. For most genetically determined defects of complement, the screening test will give a result of 0. So it's pretty much unequivocal. The only exception to that would be partial deficiencies of C2 and C4 in the classical pathway that can sometimes give you low but present activity on the CH50, and you might need to look at individual levels of C2 and C4 in that circumstance to see if that's a problem. So nowadays there are many, many molecular methods that are applied for diagnosing immune deficiency based on the clinical suspicion and the results of screening tests. These include a whole array of flow cytometric studies looking at different surface or intracellular molecules, as well as other molecular methods, DNA blots, RNA blots, protein blots, and then nucleotide sequencing or other methods that can detect mutations. Nowadays there's nucleotide polymorphism arrays and things of that nature that can be employed as well. So in summary, primary immune deficiency, I think, is more prevalent than most suspect. It is important to maintain an index of suspicion. Screening is probably cost-effective for the more common disorders. Infection is the most common presentation, usually respiratory and GI tract. There are many additional clinical features that can aid or guide the diagnostic evaluation, and it's important to remember other manifestations related to the immune system are very common in many of these disorders. Serum immunoglobulins, vaccine antibodies, lymphocyte phenotype, and T-cell function are the general screening tests that are applied. There are a variety of more advanced biochemical tests that can be used to focus the diagnosis. Nowadays, you really do have to go to the genetic level for many patients to establish a definitive diagnosis. And of course, most practicing allergist immunologists aren't going to carry the evaluation from start to finish, but at the very least can identify individuals who will be worth more evaluation. So I just want to run through one very quick example of how this would work in real life. So this is just one patient, a 2-year-old male. He's had lots of ear infections. He's had 3 episodes of chest X-ray documented pneumonia. He's had 1 episode of pneumococcal meningitis and 1 episode of pneumococcal sepsis. This is a relatively extreme infection history. I hope that most clinicians would look at this child and say there's got to be something going on with this kid's immune system. This is really too much. So if we look at screening immunoglobulin studies, clearly this is agammaglobulinemia, almost undetectable IgG, no detectable A or M. In this circumstance, you wouldn't expect to find any specific antibody, of course, and you look and you see no B cells in the peripheral blood. So this is, by definition, agammaglobulinemia. There are several different forms of agammaglobulinemia, all having an identical clinical presentation. So the X-linked form, which of course would manifest only in males, is Bruton's or X-linked agammaglobulinemia, but there are a lot of autosomal recessive forms as well. So XLA accounts for 85%. Our patient is a boy, so the first thing that we would want to look at is the Bruton's kinase. This is just a diagram to show the relationship of the different molecules that are defective in agammaglobulinemia. They're all components of the pre-B cell receptor as well as intracellular signaling molecules involved in B cell development in the bone marrow. So in our patient, we could do a Western blot, a protein blot for BTK, and use a radio-labeled antibody to detect the BTK in electrophoresis of a lysate of these patients' lymphocytes, and we can see that in the normal control and in the mothers that there's a band that corresponds to BTK, and it's absent in patient 1, and it's very much reduced in patient 2. So this would be a strong suggestion that the problem, of course, was X-linked agammaglobulinemia, and if you wanted to, you could undertake a gene sequencing to prove it. If you had a female with that clinical presentation, or if you studied a boy and you found apparently normal signal for BTK, then you might move on to look at other molecular defects associated with agammaglobulinemia. And so this is just an example of an electrophoresis of restriction nuclease digested genomic DNA that is probed with a radioactive probe for the IgM heavy chain constant region gene. And we can see there's 3 samples of where there's a hybridizing band and 2 patients with agammaglobulinemia where there is not, indicating that they've had deletion of the IgM heavy chain gene as the molecular defect underlying their presentation of agammaglobulinemia. So the last slide contains a variety of resources on the internet that give a wealth of clinical and a lot of molecular information related to immune deficiency, including this one you may find quite interesting, which is much more related to presenting diagnostic algorithms with different clinical features related to immune deficiency, as I've discussed here. And that's it. Thank you.
Oh, that's beautiful. Thank you so much. That was great. So we have opportunity to ask some questions now, and if anybody would like to ask a question, your microphone on the left side has a red slash through it. If you want to speak, just click on the red slash and it'll unmute your microphone so we'll be able to hear you. If you don't have a microphone, go ahead and type in a question on the chat, and we'll be able to see your question on the little chat box. Any comments or questions? Anybody here have any comments or questions?
Dr. Bonilla, this is Paul Dowling. When you were talking about genetic testing and to get the genetics for a particular disorder, like the example you just gave, how important do you think it is to track the genetic defect down, specifically if you think someone has, agammaglobulinemia? Because an issue comes up with, 1, availability of these tests, and 2, probably just as important is the cost that's associated with a lot of these tests that sometimes can be quite a burden for families.
So that's a good question. It gets bandied about a lot. From our perspective, there's a lot of interest in understanding the genotype-phenotype correlation. And as we learn more, I'm not talking about agammaglobulinemia, I'll get back to that in a second, but speaking more generally, as we learn more about genotype-phenotype correlation for some of these diseases, it actually can carry important prognostic value. And so we might know that the risk of certain forms of malignancy may be very high with certain mutations and may be somewhat less in others. So the answer to your question depends, at least in part, on which particular disorder you're investigating. With regards to agammaglobulinemia, I think you can make a case that it may not be essential, although it is important for family planning. So if you can determine that an individual is a carrier of a particular mutation, then obviously that has implications for future reproduction and potential risk. In that circumstance for agammaglobulinemia, it would come up most commonly in the setting of X-linked agammaglobulinemia. There are non-genetic tests that can be done that are a little bit less expensive than the sequence, but given the trend in the cost of genetic testing, which is going down, 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 down on an almost daily basis, I think that the cost of actually doing the sequence very soon will be even less than the cost of doing the biochemical test. So I think the cost balance in the next few years is going to shift, and it will not really represent more of a burden than other methods that we might use to make a diagnosis of something like BTK. And in the case of autosomal recessive agammaglobulinemia, you can't really make a specific diagnosis without doing the genetic sequence. So I think your point is very well taken today, but within a few years, I think it will be less of an issue.
Of course, the next thing that will happen, of course, is that more and more diseases will be discovered, because most of them we probably haven't even identified. As we do more DNA sequencing, we're going to find more things that have gone wrong.
There's no question of that. I mean, some people estimate, well, how many genes are there in the genome? Roughly 30,000.
30,000.
Yeah, the number keeps going down. 50% of those genes are expressed in hematopoietic cells, and of course, many of those are expressed in other tissues, but there's a relatively large number that are hematopoietic cell specific. So there are many, many genes that are likely to have an immune phenotype of one kind or another, and people are talking, not about hundreds, but about potentially thousands of gene defects that may be associated with immune phenotypes. I guess we're just going to have to wait and see. But I think, the cost of doing a whole genome sequence today, just the sequence, is about the same as what it cost to sequence one gene 5 years ago.
Right. It's an amazing thing, and we have a gene sequencing guy here now who's willing to sequence all of the genes associated with immune deficiencies on a microarray chip.
Yep.
So we can send one sample and get all of the genes sequenced. But my understanding is that the expense and the difficulty of that isn't in the sequencing, it's in figuring out what to do with all the results.
That's exactly right. So my comment before that the cost of sequencing one gene, the genome now is the same as the cost of sequencing one gene 5 years ago is true, but it's a lot easier to know how to interpret one gene sequence. It is much, much more challenging to interpret the genome. However, there is, obviously a lot of work going on in bioinformatics nowadays that I think will ultimately lead to a reduction in the labor cost of interpretation as well. So, we're early in the process of, genomic medicine, but the pace of advances is amazingly rapid, and I think it's going to be a relatively small number of years before almost every patient is going to be having some kind of genetic analysis as part of their disease evaluation, not just in allergy immunology, but probably many other specialties as well.
Definitely an exciting field. Now, I know that you were the editor of the last practice parameter on immunodeficiency. Are you working on an update of that?
Yes, the update is in progress, and I hope very much that the manuscript will be done before the end of the year.
So we'll keep an eye out for that. That'll be very interesting. Brock, you've been very quiet. You always get the last word. Do you have any comments or questions? Nope, he's not saying anything. All right. Well, we're going to have to stop there, but I really appreciate it. We appreciate you're willing to share this information with us. We'll have to have you come back and tell us what new information you've come up with. So we're going to stop there. This has been Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City. Have a great weekend, everyone. Try to stay cool, and we'll see you next time. Thank you.
Thank you. Bye-bye.
Bye-bye.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to acaai.org. See you next time.